Hi, we are going to today talk about alterations in renal and urinary tract function. So we're going to go through both the kidneys and the urinary system. Mainly with the urinary system, we'll talk about obstructions and neurogenic bladder, things like that. Renal, we'll talk about nephrotic disorders, of course, and also obstructions in that case. And then we'll move through some of the glomerulonephritises and then kidney failure in general. It's just going to get worse and worse. Okay, so let's talk about what the kidneys do in general. I kind of depend on a little bit of a background in physiology for this, but in general, the kidneys are these comparatively small organs. I mean, they're but for an organ, they're pretty decent size, I guess. But when you compare it to the overall size of the body, they're not really taking up much space, but they handle a fourth of the blood flow, which makes sense because their job is to filter blood and to control fluid volume, which essentially will kind of translate to blood pressure. So there's blood that goes in, so it starts out with the big renal artery that kind of branches off the descending aorta, but the blood flows in and then it's filtered by this glomerulus. And we'll talk a lot more about the glomerulus and what it's doing, but when we talk about glomerular diseases. But that's essentially what's happening is blood flows in and then it gets kind of trapped in this capillary ball. It's under, it's being pushed into this kind of confined area. And then fluid will kind of filter out, fluid, water with ions in it, maybe some amino acids, things like that. Little stuff will get out. But the big things like blood cells and larger proteins like albumin and the globular proteins, those stay in. And then it moves back out. What doesn't get filtered, what doesn't move into the nephron, will then move back out the efferent arteriole. Okay, so that's essentially what's going to happen. We'll get more into it, of course. So the left and right renal artery and then the afferent arteriole blood goes into the glomerular ball, or the glomerulus, the capillary ball, and then and that's kind of what's taking place. And then what goes in, if we think that a fourth of the blood is going into the kidneys to begin with, and then about 20% of that is actually moving into the nephron, if it doesn't get reabsorbed, you're gonna run out of fluid really fast. So most of that water and ions and things like that, most of that stuff is reabsorbed. Most of it in the proximal tubule in the first part of it. Amino acids, things like that can get reabsorbed. Glucose, stuff that we want, and then we just kind of leave the bad stuff and we just say, we'll just let that go as urine. Okay, so that's pretty much how it works. There are about 1 million of these nephrons. So when we talk about kidney disease or kidney failure, what happens is these nephrons kind of go away one by one, and the kidney will atrophy, and then you're not able to do that filtration. So to start, we're going to start with the urinary system. You can kind of see the urinary system in a nutshell here. You've got the kidneys that are producing the urine, moves through the ureter. Actually, it kind of collects in the kidney itself in something called the calyces, the calyx, and then so this urine is being produced out here in the outer part of the kidney, and then it just kind of drips into these calyces, into this area that we call the pelvis, and then the urine will kind of keep flowing down and fill the bladder. And then when the bladder gets to a certain fullness, the detrusor muscle around it contracts, and then it pushes the urine out through the urethra. Okay, so we have some control of that. We'll talk about it a little bit more, but that's generally what we're talking about. We're talking about urine production in the kidney, moving through the ureter, collecting in the bladder, and then moving out through the urethra. Okay, so anywhere along that path, you can have an obstruction. Okay, and this shows some. The next slide's also going to show some areas where obstructions can take place. You can have kidney stones. You can have a stricture, which is where you've sort of lost the ability for the usually it's like scar tissue or something that makes it lose its ability to stretch. So that can kind of anything that kind of interrupts flow. That's what we're talking about. You can see benign prostatic hyperplasia, BPH. And so where the prostate gland expands, gets larger, and starts to push on the urethra, which is going to restrict flow. So that's what we mean by obstruction. It's just pretty much exactly what it says. Can be caused by anatomical or functional deficit. We'll also see that we could have something called neurogenic bladder, where the bladder doesn't empty the way it's supposed to. And so that's considered also in this category of obstruction. So the severity is based on a lot of different things: location, how well, I mean, if it's cut off completely, if you've completely obstructed flow, or if you've only partially obstructed flow, so completeness, involvement of ureters or the kidneys, is it upper, is it lower, the duration, how long it's been going on, and what's causing it. Okay, so what's causing it could have a lot to do with treatment, obviously, if it's a tumor or if it's kidney stones. So kind of digging a little bit deeper, and kind of repeating myself, actually, to be honest with you. Obstructive disorders, they can occur anywhere. So they can be developmental defects, pregnancy, or a tumor, whatever you want to call that thing in there that looks like a pregnancy. But a tumor can also sort of push on the ureters. Okay, BPH, we mentioned that, which is going to happen down here in the lower area. Tumors, kidney stones, which we'll talk about. So it depends really on the site, the cause, the rapidity with which it develops, all those things we already said. And there's going to be pain involved. And remember, this is referred pain. We don't have an area of our brain dedicated to what's the kidney feel like, but it's going to sort of hijack those other pain receptors. And so we're going to feel referred pain. It's going to be kind of in the general area. Remember, the kidneys are retroperitoneal, which means they sit behind the peritoneal cavity, which holds all your guts in for the most part, your intestines and stuff. And so they kind of sit back behind that in the back area. So that's where you're going to feel pain if it's in the kidney. Your bladder sits lower, and so you're going to feel it in the lower quadrant if it's affecting the bladder. Okay, so signs and symptoms: pain and type related. Yeah, just said that. Hypertension. So hypertension is another problem when it comes to obstructive disorders. And when you're reducing urine flow, a lot of times the kidneys will misinterpret that as saying that it needs to conserve more water. So your renin, angiotensin, aldosterone system may be activated, and then you'll reabsorb more water back into the body. And so that's something that can take place in specific circumstances. But in general, if you're not moving fluid out, then it's going to collect, first of all, in the kidneys and probably ruin your kidneys if you don't do something about it. But it can also lead to high blood pressure when that damage may take place. So let's talk about kidney stones, or renal calculi. So they are polycrystalline structures. Remember, a crystal, I don't know, maybe you've heard of growing crystals. And what you do is you supersaturate water, and you put in certain molecules. Let's see if we can name some of these. Calcium phosphate, calcium oxalate. If you put a whole bunch of that into water, and eventually what's going to happen is a couple of them are going to stick together, and then more of them are going to stick to that, and they just kind of grow they just kind of grow from there. We call that a nucleation point, where it sort of starts to grow, and then it just continues to grow and can grow larger and larger and larger. So it starts from that supersaturated urine. There has to be that nucleation site, the presence of a nucleus for the formation, and then there are certain processes that can help prevent that from taking place. So magnesium and citrate, those can bind to molecules to keep them from collecting or forming a stone. And so we might have a deficiency of those. And then there's just the question of, some people are more prone to get kidney stones than others, and we really don't understand why some people might get them and some people don't. Some people have, a high calcium diet, but they don't develop calcium stones, while others do develop calcium stones. So there's more to it than just, you can't really guarantee that you're going to make them or not make them. So growth of stone via crystallization or aggregation. Kidney stones are classified according to the minerals that make it up. So I mentioned calcium oxalate, calcium phosphate, struvite, which is magnesium, ammonium phosphate, something like that. Uric acid, which uric acid is associated with gout, and purines. so those are also, so basically you can get gout in your kidney, or you can get kidney stones in your toe, whatever, but that's caused by this supersaturation of uric acid, too much uric acid. Okay, so they hurt, they're painful. So we have a couple of different terms. You've probably heard of colic. Usually we hear of colic in like a colicky baby. And colic in general is a pain associated with a lot of things, but associated with kidney stones. Colicky pain would mean that it starts and stops abruptly. It accompanies the stretching of the collecting system. Okay, so that means that a kidney stone might move into the ureter, and that can cause pain. It can stretch it out and cause pain because that's not supposed to happen. And so we consider that colicky pain. It's acute, intermittent, and excruciating in the flank and upper quadrant on the affected side, so that would be associated with the kidney. That's where you're going to find those kidneys. May radiate down to the bladder area, okay? Bladder area, or even lower to the perineum or scrotal area. Okay, so that's colicky pain. It just sort of depends on where those kidney stones are finding themselves. Non-colicky pain, that's going to tend to collect more in the kidney. Okay, so remember the kidney has, the functional nephron areas up here, but then those drain down to the calyces, and those calyces drain into the pelvis. Now, if we have kidney stones that are in there that are kind of jamming up its ability to leave, then what happens is fluid can build up, hydronephrosis, so fluid can build up and stretch that out, and that's going to cause more of a, I would say more of a dull pain, but it's going to be more of a constant pain as long as that stretching is taking place. So it can be mild to severe. It can be exaggerated by drinking large amounts of fluid. If you add more fluid to the kidney itself, then it's going to build up and it's going to cause more of that stretching, which is going to exaggerate it. So caused by stones that produce distension of the renal calyces or renal pelvis. So it could be, so you've got stones in there, and then you've got water in there, and it's kind of pushing out on it. That's going to be the non-colicky pain. All right, so risk factors: gender, age, race, some of our normal players. Geographic location, so what your diet is, seasonal factors, fluid intake, what your job is. So there are lots of different things that have shown to correlate with getting kidney stones, although it's not just absolutely known. There are still some mysteries involved in it. Evaluation, how are we going to look at it? Well, we can take a picture. Okay, so you can have a MRI or something like that, or an X-ray, and you can find out if there are some solid stones in there. You can do a 24-hour urinalysis. You can just keep all your pee for a day, and then kind of dig through it and see if you can find any of these crystals or some evidence of crystal formation. Okay, and treatment, high fluid intake. So since we're talking about, in a lot of cases, supersaturated fluid, then if you increase the amount of water, then that's going to reduce the formation of these kidney stones. So you can decrease the dietary intake of stone-forming substances. If they're based on calcium, you might want to reduce calcium levels. Okay, so that can help. Stone removal. So now we can just go in, cut it open, and take the stones out. That's a surgical procedure, but it's optional. And then sometimes they can pass on their own and then you'll have to continue to watch your diet and make sure that you drink enough fluid, don't get dehydrated, so you don't form more. Okay, so we kind of mentioned this before, but hydronephrosis. Hydro, of course, always refers to water, at least usually refers to water. Sure, there are exceptions, but hydronephrosis is when water collects in the kidney, and really we're talking about urine. Okay, so it's dilation of this renal pelvis, which is this area here. This is the pelvis, and the calyces, which are feeding into the pelvis. Okay, so it's dilation of the renal pelvis and the calyces, and atrophy. I'm not sure what right and left mean there, but an atrophy of the actual area where the nephrons are. okay, the renal tissue where the nephrons are. So maybe that's supposed to be all the way down in this area. Those renal pyramids are supposed to move all the way down here, but because you have an obstruction to the flow of urine, because something's blocking it from moving out, then what happens is the fluid will collect in that area and it causes stretching, and it can ultimately, you know, cause atrophy of the actual functional part of the kidney. So maybe acute or insidious in onset obstruction may occur at any level of the urinary tract. So it doesn't have to be right here at the exit. It could be down in the bladder. It could be anything that's causing an increase in pressure that's pushing back, pushing up to the kidney. So we don't like stasis of urine. We don't like it when urine isn't flowing. We don't like it when anything isn't flowing in the body, because bacteria do like it. They like it when things aren't, when they're not, you know, as soon as they start to kind of divide, they get whisked away. They don't like that. It makes them too easy to kill. So if you have stasis, then these bacteria can kind of collect in that area and gives them a chance to grow and cause an infection. Okay, so that's an increased risk there. And in the same way, if you have an obstruction, even if you're not initially prone to kidney stones, you can have the formation of kidney stones. Okay, so these crystals may not be passed efficiently, and so you can have a stone formation. So that kind of makes sense. So stone formation treatment, just quickly, this is just kind of a repeat, but we've got the calcium oxalate, calcium phosphate stones that can develop. They're a lot of times contributing factors, hypercalcemia, so vitamin D intoxication, bone diseases because you remove the calcium back in. It could be because the kidneys aren't getting rid of the calcium the way that they're supposed to. So there are a lot of different things that can cause that to happen. And you know, of course, if there's an underlying cause, you want to treat that. Increasing fluid intake is always good. Diuretics keep the flow going, keep more fluid being produced. And then we have some others down here: magnesium, ammonium phosphate, the struvite, stones. So some of the same things. Increased fluid intake. Uric acid, like I mentioned earlier, is associated with gout, a high purine diet. Purine, that's what it is. So a high purine diet, you can treat it with allopurinol, which reduces the purine in a roundabout way. Mimics it, and so you can actually take something. It's a gout treatment. Allopurinol is a gout treatment for when there's too much uric acid, essentially, and so you can reduce it that way. Cysteine tends to be inherited, and that's cysteine is an amino acid. So just kind of a brief overview without getting into too much detail of what's going on with all of them. All right, so let's talk about some lower. So now we're moving down, we're moving out of the kidney, and we're still talking about obstruction, but we're going to talk about the bladder, and we're going to talk about something called neurogenic bladder. So neurogenic means that it's generated or it results from some problem with neurons. Okay, so some problem with the nervous system. So we'll go through that. Detrusor, hyperreflexia. Remember, your detrusor is your that muscle that surrounds the bladder that squeezes. It squeezes, and that's what squeezes the urine out. If it's hyperreflexia, well, that means it's squeezing out when you don't really want it to squeeze out. So that's going to be considered an overactive. Areflexia, A usually means not. So if you're not getting that squeezing at all, then you might have an underactive. That could also be considered kind of an obstruction because now you're not able to push the urine out. So overactive bladder syndrome, frequency, urgency, nocturia. So we'll get into some of these overactive bladder conditions. All right, so obstruction, just straight up obstruction. We're talking now about lower urinary, so that could be anything that's blocking movement from the bladder out. Okay, so urethra, so you could have stricture of the urethra, prostate enlargement, so the prostate gets too large, it starts to push on the urethra, pelvic organ prolapse, partial obstruction of the bladder outlet or the urethra, so you could have an obstruction here that kind of blocks fluid flowing out of the bladder. So anything that's kind of either fluid is moving in, it might be moving the wrong direction in the case of a prolapse. So partial obstruction of bladder outlet or urethra, low bladder wall compliance. Okay, so so that's also if the bladder wall can have an effect. So let's talk about the Micturition reflex. Okay, so I like to think of it in terms of a baby. When a baby doesn't have anything but its reflexes in terms of urinating at that point. So it's not able to hold it. You can't say, oh, not now, now it's not a good time. However, you still know that a baby, or maybe you don't know this, a baby will only urinate after a while. It allows the bladder to get full, and then it will push and squeeze it out, and it's just a continuous cycle. The baby doesn't just drip out urine all the time, and neither do we. Okay, so we as in human adults, I assume. I don't know if there are any babies listening. Maybe there are. I don't know. So, but it begins in essentially that's what we're trying to figure out. We're trying to say, okay, why does it wait until it's stretched to a certain amount and then contract? Okay, and it's a pretty straightforward process. So it begins when the bladder contains about 150 to 250 milliliters. So I guess when it's stretched to a certain level, and it will send a parasympathetic signal saying, hey, I'm stretched. And then you will have activation of both the sympathetic and the parasympathetic. So, but the parasympathetic is going to then say, this is important, rest and digest. Your parasympathetic activation is going to say, contract the detrusor muscle. That's what it's going to say. Your sympathetic was holding the internal sphincter closed, so it was holding it closed. So that was automatic. Okay, you have control of the external, which is what this purple line is showing. That's you being able to control the external sphincter to pinch it off. Now, but the rest of this all happens kind of automatically and involves both parasympathetic and sympathetic. The way to think about this is parasympathetic tells you to go, rest and digest and urinate. Okay, we can add that. So rest and digest and urinate, that's parasympathetic. It's going to contract that detrusor muscle. Sympathetic is the fight or flight or don't urinate. So it's going to keep that internal sphincter closed, and it's going to prevent urination, which allows it to stretch. That's important because we just mentioned something called neurogenic bladder. Neurogenic bladder is when the neurons are messed up, and guess what? These are the neurons that can get messed up as a sympathetic and parasympathetic signaling. So in general, the reflex happens because there's stretching of the bladder, sends a signal to the spinal cord, and then the spinal cord will send a signal back saying, okay, contract the detrusor muscle, release the internal sphincter, and then urine will come out. So that's the way it happens in a baby. After people get control of that at some stage, then the brain will override that and can say, okay, now is not a good time, and it can sort of stop that reflex. Okay, hopefully, right? That's the problem. We're talking about pathologies. And sure enough, there's something, as I said, called neurogenic bladder disorder. So there's hyperreflexia, which is when it's overactive. So if the sympathetic system is saying don't go, and the parasympathetic system is saying go, then it kind of makes sense that in hyperreflexia, when it's overactive, that maybe that sympathetic signal isn't getting there. Okay, so maybe the sympathetic signal saying release or contract that internal sphincter isn't happening. The internal sphincter is open. The parasympathetic nervous system, the one saying contract the detrusor muscle, is still active, and so you go. Okay, so hyperreflexia is overactive bladder. It's failure to store the urine. That's storing of the urine is going to be, we can think of that as being a sympathetic response. So if you think back, maybe, hopefully you remember this, remember parasympathetic signals kind of come from the brainstem and they come from the sacral area. Okay? And these sacral neurons are the ones that we're interested in because those are the ones that are telling your bladder to contract, your detrusor muscle to contract. It's these sacral neurons. Those are the parasympathetic signals. If there's damage to those, then you're not going to be able to contract the bladder, not as easily. Okay, so now if there's damage to the sympathetic neurons, which are kind of lower thoracic, upper lumbar, there's damage to these, they're the ones saying don't go. So if there's damage to those, then that's going to be overactive. So hyperreflexia, lesions above the sacral level, okay, because that's going to be an effect on the sympathetic side of things. Okay, so if you damage those, you're not going to be able to store urine, hyperreflexia. So areflex bladder, we've already kind of explained that. So that's a failure to contract and empty. That's neurological disorders affecting motor neurons in the sacral cord. Okay. So now we're getting down here where the parasympathetic signals come out that control the detrusor muscle contraction, okay, and bladder emptying. Okay, so this could come from an infection, it could come from MS, it could come from a tumor, it could come from a spinal cord injury, any kind of diabetic neuropathy. There are lots of different things that can damage neurons, and those can have an effect on your ability to either store urine or to not store urine, to get rid of it. Okay, so causes, here's another list: stroke, Parkinson's disease, spinal cord injury, any kind of injury to the cord or roots, herniated disc, diabetic neuropathies, MS. Okay, so any of these can cause neurogenic bladder. So it's not uncommon. I don't want to say it's common because doesn't happen to most people, but it does happen. You'll see it. So compensatory changes. So now we have, so going back kind of to the obstructions, if you have an obstruction or if you're not able to get urine out of the lower urinary system, then you'll try to fix that. So there's compensatory stage, which could cause your detrusor muscle to hypertrophy. It's trying to push it out. It can't push it out. It's going to squeeze harder. Okay, as long as it's stretched, it's still getting that signal to squeeze, and so it could get larger. So hypertrophy and that might, kind of take care of things for a while, but that's not a good fix. It's not permanent. You're not getting rid of the initial problem. So excess urine in the bladder may diminish the ability to suppress urination. So the bladder can stretch. So for a while, it can stretch, and you may be able to go through things normally. However, it may stretch to the point, that's more of a decompensatory, a failure of compensation, but it may stretch to the point that you can't suppress it anymore, and urine just starts to flow out. So another problem is diverticuli start to form from excess pressure, so a weakening in the wall of the bladder, so the bladder outer membrane. You could have a weakness where it sort of pushes out, and then you've got stasis in urine. Okay, you've got fluid that's collecting in that area. So, and which kind of gets us to our decompensatory stages. So that's the failure of compensation. You tried, or your body tried, it couldn't do it. Increased frequency with a weak small stream. So that's what's going to happen. Urine will remain in the bladder, which increases risk of infection. Yeah, we don't like things to just sit for too long. And so infection is going to be burning on urination, cloudy urine, symptoms of cystitis or a UTI. So severe overstretching decreases the ability to contract. We saw that with the heart too. When the ventricles stretch too much, they can't contract as much. Same thing. That's just kind of a property of muscles. When they're too stretched, they can't contract as well. So what we end up with, possibly, is urinary incontinence, which is an involuntary loss or leakage of urine that is sufficient to be a problem. It affects a lot of people, 13 million Americans. So there's different kinds. Stress incontinence. Stress incontinence is when you have, we're not talking about stress like, oh, I'm so stressed, but that's like coughing, sneezing, laughing, lifting, anything that's kind of sort of producing pressure, intra-abdominal pressure. So it's pushing pressure. It's more common in women because of a weakened pelvic floor, especially after pregnancy, because those muscles that are kind of holding that together may have been displaced, something like that. So that's stress incontinence, just something that pushes unexpectedly, and if you're not able to sort of hold that in, then it can leak out. Overactive or urge incontinence, this has to do with the detrusor muscle kind of getting a little bit too antsy about pushing it out. Now that could be neurogenic, or it could be some other kind of mystery cause, but it's where maybe psychological, I don't know, but it's where that detrusor muscle is activating and trying to push the urine out, and that's going to be, oh my gosh, here it goes, there's my detrusor muscle sort of betraying me again, and that's going to be an urge. You're going to feel that as an urge incontinence, and it's obviously overactive. So it may or may not involve involuntary loss of urine. You may be able to stop it with your external urethral sphincter, but it is definitely there. You've got the urge, and it's frequent. So overflow, that might be that you have so much urine collecting that that it exceeds the amount of pressure that you can hold back, and that's an overflow. Okay, so the bladder is stretched out, there's too much urine in it, and it well, it's in the name, it overflows and comes out as incontinence. So there's others: decreased bladder compliance, distensibility, if it can't stretch the way it's supposed to stretch, those kinds of things. Okay, so the bladder, this is, I think, the last, well, no, it's not, because we haven't covered cystitis yet. But the bladder, it's also susceptible to cancer. Okay, so we kind of covered this in cancer and what cancer is, and there really isn't any new information saying that it is the most common form of urinary tract cancer. In the US, 90% derive from transitional cells. Remember, transitional cells are those kind of unique cells that exist on the bladder because it stretches and then contracts and stretches and contracts. So that's where we find a specific type of cell where those cells can become cancerous. So transitional cell carcinoma, if it happens in a secretory, then it's going to be an adenoma, so it's kind of the same rules. So this is more common in males over 60s. Early detection means that you can kind of get it quicker. Maybe when it's in situ even would be ideal. Etiology unknown, highly associated with cigarette smoking, the breakdown of products of aniline dyes used in the rubber and cable industry. So this is where you see a lot of people that work in a certain field, and they're all getting bladder cancer. And so you say, okay, well, there's got to be something, and then you trace it back and you figure out, okay, it's these aniline dyes. I'm not sure what those are, but they're associated with the rubber and cable industries. So signs and symptoms: painless hematuria. So now you don't necessarily feel pain. In this case, you've got breakdown of cells and production of blood, and so you'll see the blood in the urine, and that can be an indicator that cell damage is taking place, which could be from cancer. So occasionally, frequency, urgency, and dysuria may also occur. So let's talk about UTIs. UTI, urinary tract infection. It's inflammation of the urinary epithelium, so the cells surrounding. So if we're talking urethra, it's the cells that are kind of surrounding it, the skin cells that are surrounding it. But the bacteria get in and they can infect it. So whether it's in the bladder, which is the case with cystitis, or it could be in the kidney. Okay, so it could move. And if you think about it, bacteria are probably going to enter through the urethra. Usually they're going to enter through an opening. And so that opening is going to be the urethra, and then it can travel up to the bladder. And then from the bladder, they can keep traveling up. They've got little flagella on them. It's usually some kind of E. coli, flagellated E. coli. So they're kind of swimming up, and then they could make it all the way up to the kidney, which is a pyelonephritis. Okay. Let's see. So UTI, second most common type of bacterial infection. Most are caused by E. coli, as I just mentioned, involve both lower and upper structures because of their ability to cause renal damage. So upper, when we talk about upper, we're talking mainly about the kidneys. When we talk lower, we're talking bladder on down. So upper is affecting the kidneys, so that can cause renal damage, which tends to be worse or more lasting. So upper, inflammation of the kidney pelvis with marked systemic manifestations of infection. We'll talk about pyelonephritis, which is kind of what we're referring to here. And lower propagates in the urine, causes irritative symptoms with voiding, frequency, burning, cloudy urine. That's from that infection and maybe some white blood cells trying to fight it off. And minimal signs of infection, minimal systemic signs of infection. So it tends to mostly just be in that area without fever and stuff like that for whatever reason. So manifestations more common in women 20 to 30, full bladder fullness, frequency, small urine volume, chronic pelvic pain. These are some of the things that you can see. Your bladder will feel like it's full, maybe even if it isn't. Your frequency will increase because you're going to want to void more, but there's not going to be very much urine, and you're going to, in general, feel pain in the pelvic area or wherever it is. Because here we see acute cystitis, and acute cystitis, the cystitis refers to inflammation of the bladder. Okay, so that's going to have those same manifestations: frequency, dysuria, urgency, lower abdominal, suprapubic pain. So in the area where the bladder is. So treatment, antimicrobial therapy, yeah, take antibiotics, that works. Increased fluid intake, avoidance of bladder irritants, and urinary analgesics. Okay, so something that moves through the urinary system and is cleared by the kidneys. So risk factors more common in pregnancy. Okay, more likely to progress to pyelonephritis in children. We haven't talked about pyelonephritis yet, but that's when it affects the kidneys. And the elderly are at high risk due to immobility, benign prostatic hyperplasia, BPH, constipation, senile vaginitis, poor immune function, just a lot of things that sort of prevent good flow of urine and emptying of the bladder frequently, and water intake also. Even in the elderly, sometimes they don't drink enough and they get dehydrated. Okay, so so pyelonephritis is a renal disease affecting the tubules, interstitium, and pelvis of the kidney. So we're going to first talk about the acute form of this. So now we're talking about a kidney infection, and the pyelo refers to the pelvis. So this is the picture I've been trying to draw, where you can see sort of the calyces up here, and then they drain into that pelvic area, the renal pelvis, and that's really what pyelonephritis is referring to. But it says affects the tubules, interstitium, and pelvis. So it's kind of getting up into the kidney, and it's going to move, it's going to travel. They're bacteria, they don't know where they're supposed to live, they just try to go everywhere. Okay, so it can affect the pelvis, and it can move up to the interstitium, the tubules, and you're going to have an infectious process that's going to take place. So acute infection of the renal pelvis interstitium, mostly E. coli, and there are some others named here. Ascending route of infection through the lower urinary tract is most common. So this is what I was saying earlier about your bladder. You could have a bladder infection, and then that bladder infection could move up through the ureter and into the kidney. So we call that the vesicoureteral reflex. Ureteral? Yeah, but anyway, that's the reflex up. Not sure why I'm having trouble with that word. So infection can also occur through blood. Obviously, bacteria don't care. It's just easier for them to move in through an opening, but it can also, you can have bacteria from the blood that also can affect it. Okay, so risk factors: catheterization, putting things in there, putting foreign items in the urethra is a great way to just introduce bacteria and say, here you go, we're just going to put you right in there, and then that can kind of go from there, and then you have that that vesicoureteral reflux, and so you've got the movement where it's going to move up to the kidneys. Pregnancy is it happens more frequently with pregnancy. Neurogenic bladder, so neuronal damage, which can also lead to have an effect on stasis of urine flow. So clinical presentations: chills, fever. So now we're talking about systemic. Okay, so we didn't really talk about that with cystitis. But then when it moves up and it spreads up into the kidney and it gets to become interstitial, then we start to see more of a systemic symptoms. So chills, fever, headache, of course back pain, because we've got It's affecting the kidneys, tenderness over the costovertebral angle, and general malaise. So yeah, so areas of the kidney, and then the typical systemic symptoms: chills, fever, malaise. So bladder irritation can happen because the bladder is probably going to be affected as well. So dysuria, frequency, urgency. Okay, so now acute pyelonephritis is sudden onset, usually doesn't last as long, but if it can't be fixed and it is persistent, it's going to kind of wipe out your kidney. So chronic pyelonephritis, persistent or recurring episodes of acute pyelonephritis that leads to scarring. So now we have damage that's taking place, and you can kind of see in these pictures what that can look like. But and it just makes sense. I mean, you've got this constant assault that's causing an inflammatory response. Inflammation tends to cause damage and laying down of new collagen and scar tissue. So risk of chronic pyelonephritis increases individuals with renal infections and some type of obstructive pathological condition. So that might get back again to renal stasis. All right, so that's the, well, I mean, we've kind of moved through bladder and also into the pelvis, but now, or into the kidney. But now we're going to talk about the glomerulus. So remember the glomerulus, or that capillary ball, and that capillary ball is where filtration takes place. I don't know how much you remember of this, but that capillary ball is where you sort of filter out things like, and this is really important, proteins. So you shouldn't have proteins in your urine because that glomerulus is going to stop them when it's working right. So you shouldn't have a lot of proteins in your urine. You shouldn't have blood in your urine. Blood cells shouldn't be able to get through and move into that nephron. So the glomerulus is supposed to stop all that. So the glomerular capillaries and the Bowman's capsule are made up of epithelial cells sitting on a basement membrane. I'm not going to draw that because there's a picture of it on the next page. They are so tightly attached to each other that they share one basement membrane. Now we're going to have to understand a little bit of this anatomy to kind of understand how these diseases work. So so on one side, they've got, you've got epithelial tissue with little, I said I wasn't going to draw it, and I'm really not. but then they have there are little slits in it, and then there's this basement membrane, and then on the other side there are these things called podocytes, and they're little foot processes. They're little cells that lay down these feet that kind of help with absorption. And I'll tell you, these foot processes, this is something to remember. The foot processes, or the podocytes, that's what's really stopping proteins from moving through. Okay, that's important, because if we start seeing proteins, massive amounts of proteins in the urine, then we know with all likelihood that these podocytes are damaged. They're not doing their job, because that's one of the big jobs of these podocytes. Okay, so let's look at this. Glomerular filtration, fluid, blood, moves in through the afferent, moves around in this area, and then fluid and some dissolved particles are filtered through and make it through. Some don't, and some just leave through the efferent. But that's what filtration is. If this happens, now if you can sort of imagine what happens if, like, you get a hole in this glomerulus, in this capillary ball, if you get a hole in it, you're going to have a harder time stopping proteins, and then proteins can also kind of move out of there. So I know that's a little bit of a crude way to think about it, but that's kind of what we're talking about, is if you compromise that glomerulus, you're going to have different types of symptoms. If you clog it up, what if you clog that thing up? Then that means your rate isn't going to move as much. Okay, so let me relate it back to that. So if you poke a hole in it and you just kind of tear it down, then that means the rate that fluid moves through there is going to be really high, and we call that the glomerular filtration rate. Okay, if you clog it up, that means the rate's going to be slowed down. Okay, so that means that you're sort of blocking it. You're not allowing fluid to move through, or particles, or whatever. Something's gunking it up. That's going to be a lower glomerular filtration rate. So to kind of focus on this GFR term, the GFR is the amount of filtrate produced each minute. So usually about 180 liters per day is pushed through the kidneys, And that's going to make about 1 to 2 liters of urine. If we increase that rate, if something happens that sort of compromises that filtration system, then your GFR is going to be higher. If you clog it up, okay, which is what happens with a lot of nephritic types of diseases, then it's going to be lower. You're going to have less urine flowing through there. Your GFR is going to be lower. Okay. So usually our GFR in a healthy person is pretty much the same. Now I want to point again to this little picture down here, and you can see that it shows these blood cells are really big, and there's no chance they're going to make it through there, right? If everything's healthy. But you can see there are these little slits here, okay, fenestrae or fenestrae. And so you can see these little slits here that are going to let small things, glucose can make it through, proteins can make it through, some amino acids can make it through. That's fine because we can reabsorb those. But big things like albumin shouldn't, well, albumin actually, here's the funny thing, albumin actually can make it through these slits, but they're rejected by the podocytes. The podocytes kind of have a negative charge to their membrane, and since albumin is also negatively charged, it doesn't go. Okay, so those podocytes are sort of stopping the protein. But albumin's, it's a large protein, but it can be small enough to fit through these pores, and then but the podocytes aren't going to let it go through. Okay, and that's important for reasons that we'll find out. To understand that. So disorders of glomerular function. Glomerular diseases are one of the most common forms of kidney disease. Okay, so when your glomerulus doesn't work, that's not a good sign. Maybe primary, that it originates in the glomerulus, or it could be part of a different disease. So a different disease could be the problem, but then it affects the kidneys as well. Okay. HIV, hepatitis, lupus, these are some examples, probably diabetes. It would also be included in that, and we'll talk about some diabetes-related kidney diseases. Let's see, yeah, it was changing. All right, so effects of glomerular disease in general. So if your glomerulus is infected, then you're going, or affected, then you're not going to be able to clear things. So we have this thing called urea. Okay, so urea is normally excreted at a certain rate. So what happens is, what is urea? So urea is just kind of a breakdown product of amino acids, of proteins. Okay, so proteins are broken down. They may form ammonia, and then that ammonia in the liver can be turned into urea. And urea is soluble, it's harmless, and so urea is excreted through the urine, through the kidneys. Okay, so if you have a glomerular disease, that may be affected. So we call it blood urea nitrogen. So your urea may build up in your bun level, may build up in your blood, and which is what bun is, urea in the blood. So that may build up, which is kind of going to be an indication that your kidneys aren't doing what they're supposed to do. Sudden or insidious onset of hypertension, so you may have reduced blood flow and your kidneys are going to think that you're dehydrated, and they're going to tell it to reabsorb more fluid, okay, the RAA system, which is going, or it could just be a backup of blood. If it's pre-renal and you're not getting good blood flow to the kidneys, remember, a fourth is supposed to go there, and if you can't get that blood to flow in there, then that's going to also back up into the body. So hypertension, very common. So, and if you remember from cardiovascular, when we talked about cardiovascular, we said that that diseases of the cardiovascular system can cause kidney failure, kidney disease. Well, kidney disease can also cause hypertension. So hypertension can lead to kidney failure or kidney disease. Kidney disease can lead to hypertension. So it kind of works both ways. They help each other out. All right, and edema. And we'll talk a little bit about how edema can happen. Proteinuria, skip that one. Proteinuria, you shouldn't have protein, so at least not a lot of protein in your urine. And kind of depends on what you're eating, honestly, sometimes, because we do see foamy urine sometimes, but foamy urine is usually associated with excess protein. Okay. All right, so you could have either increased or decreased GFR. It really depends on whether you're clogging things up or whether you're compromising that glomerulus. But So if you decrease the GFR, that means that you're going to have more plasma creatinine and urea. So creatinine is a breakdown product of muscle metabolism. That's a very general way of saying it without getting into all the details, but creatinine is found in the blood, and it usually moves through the kidneys at a pretty constant rate. If the kidneys are not working, or if you have a decreased GFR, then that means your creatinine isn't going to be able to move through the glomerulus as easily. It can still be secreted, so it can still kind of sneak in the back door, but it's going to be reduced, which means it's going to build up in the blood. Okay, so that means you're going to have higher creatinine in the blood, and it's not going to be cleared, so less in the urine. All right. So glomerular damage in general causes decreased glomerular membrane surface area. Okay, so the glomerulus is kind of, it's circling around, okay, that capillary ball is, and it has to have a certain amount of surface area for filtration to take place. Well, if that's compromised, then you're not going to have the surface area, which a lot of times means you're not going to be able to move as much through. It's one manifestation. We'll talk about more of those. Glomerular capillary blood flow, which triggers mechanisms to increase blood pressure. So that's what I was talking about with the RAA, if you reduce capillary blood flow. Increased glomerular capillary permeability means that you're going to have you're going to lose that negative ion charge barrier. When I say negative ion charge barrier, I'm talking about the podocytes. Okay, those podocytes which are preventing the protein from moving through, you lose that, and then you suddenly have proteins in the urine. Okay, so that's called proteinuria. So you're going to have, if you don't, now let's focus on which proteins, okay? Which protein would you most likely expect to find? Well, albumin is made by the liver and it's put into the blood, and so that's one of the first ones that are going to go, okay? You can also find immunoglobulins or globular proteins in there, but albumin is one of these first ones that go. And try to stay with me here, but if you have albumin leaving in the urine, is it going to be in the blood then? No. Okay, so it's not that simple, or it's not that hard. So you're going to have hypoalbuminemia. Emia is referring to in the blood. So you're going to have proteinuria, so the protein's going to be in the urine and not in the blood. So you're going to have too low. It's going to be too low. And that's going to encourage something, it's going to encourage edema. So when we think about, okay, this is kind of an important concept. So here's our capillary, okay? And now you're just going to have to remember, we have proteinuria, which means that we've lost our protein. Our protein is now, in a toilet somewhere. Okay, that's where our protein is. It was supposed to be in our capillaries. Okay, and when it's in our capillaries at the right concentrations, then you're not going to have a net flow of fluid out of the capillary. Okay, so the fluid in this case, we've got the way that our fluid moves. It moves out through hydrostatic pressure. But now we also know, oops, I'm not sure what just happened there. But what if we lose a lot of these proteins that were inside our capillary? That means that water is going to be pulled out through osmosis, because look at all these proteins out here. Okay? So we've lost our albumin that was in, a lot of it, that was in the capillary. So what's going to happen is that we're going to kind of have this fluid. We've got an increased oncotic pressure out here in the tissue. Okay, the osmotic pressure is going to pull that fluid in or out of the capillary and into the tissue at a higher rate. Well, that's what edema is. Edema is a buildup of fluid. Now we have the fluid outside the capillary, and the whole reason is because the kidneys are letting all of the proteins go. Okay, so there aren't as many proteins in there to hold it. If we had those proteins, then they would help hold that fluid in, but they're not there. Okay, so the proteins aren't there. All right. Okay, so So that's what this last thing says, and I hope it makes sense. So resulting hypoalbuminemia is going to encourage plasma fluid to stay in the interstitial spaces. You're going to have a collection of fluid in the interstitial spaces, which is edema. And so it's going to be systemic because it's, I mean, it doesn't really matter. All of your blood everywhere is going to have fewer proteins. So anywhere that you would be susceptible to edema, a lot of times it's periorbital. It can happen in the extremities, in the legs and stuff. We know that we can get edema there, but it can happen anywhere, and that's what we mean by systemic edema. It'll pick its favorite places at first to manifest, but it can happen anywhere. So what causes glomerular disease? The origin may be immunologic, okay, so that's what we usually think of when we think of nephritic or glomerular nephritis, okay. So it may be immunologic, it may be non-immunologic, it could be toxins, drugs, chemicals, any of those things. So it's named according to the tissue appearance. You'll see these names. I'm not going to spend too much time kind of hashing over it. But proliferative means that it's increased proliferation of glomerular cells. So that means that for whatever reason there's a buildup of these cells, and that's going to be considered proliferative. Membranous thickening of the glomerular basement membrane. So that's going to be where the capillary endothelium and the podocytes are in that membrane. That's going to be thickened. Then you would call it membranous. Or sclerotic, increase in extracellular material around the glomerulus. That's extracellular, so that's going to be like fibers and things like that are going to build up, and we call that sclerotic. Okay, so it can be diffuse, where it involves all the glomeruli. It can only affect some glomeruli in the kidney, and or it can only infect a certain section of the glomeruli. Okay, any of these, so in terms of association with the glomeruli. So all of them, some of them, only a certain part of them, or it can only affect the mesangial cells, which the mesangial cells are these cells kind of in between these glomeruli, in between these capillaries. So it can affect anything, and so you might see these names pop up from time to time. We're not really going to get into all of the different types of kidney diseases, but we are going to talk about some, and so it's good to know that different parts can take place. All right, so now we're going to cover something called nephritic and nephrotic syndrome. So the counter, or not really the counter, but another type of syndrome is nephrotic. So we have nephritic, nephrotic. They aren't diseases, they are syndromes. They are a characteristic set of manifestations. We'll just say that. And so we can classify a kidney disease. This is important. We can classify a kidney disease as being either nephritic or nephrotic. Sometimes it can start out nephritic and become nephrotic. Okay, so it all depends on a couple of very important clues. Okay, so if it's nephritic, okay, that's in general an acute inflammatory process that occludes the glomerular capillary lumen. So if this is our glomerulus, we'll say this is our glomerulus here, and then the blue is our basement membrane, and then we have the podocytes out here. Okay, that looks more like a neuron, but the podocytes that are kind of laying down their little foot processes there, that's probably a better podocyte. But if you have an occlusion, okay, occludes the glomerular capillary lumen. So if you have an occlusion, something that happens here that's kind of blocking, okay, that's going to be more in line with what's happening with a nephritic syndrome. Usually that is a inflammatory response. Usually what's occluding it, what's clogging that system up, are antibodies, okay? So usually from a type 3 type of response, which means that there's something floating in the blood, you produce antibodies against it, against all those things. Those antibodies kind of collect, form a group, okay, and then they can kind of infiltrate that glomerular wall and clog things up. That's what we're talking about with nephritic syndrome. It is characterized by a decrease in glomerular permeability. We're gunking it up, we're clogging it up in nephritic syndrome. You'll see some hematuria. This is one of the other important hallmarks of nephritic syndrome is you'll see blood that is going to be found in the urine, okay? So, and that happens because what happens is that you sort of break down this capillary wall a little bit, and so blood cells can start to move through. You're going to see when you have, so that's tissue damage that's taking place. So tissue damage is going to be what's causing the blood to move through. You're going to see some proteinuria, okay? But when we're talking about sort of the effect being in here on the glomerular side of things, then it makes sense that blood is going to move through. But if our podocytes are still initially intact, then you're still going to have that repelling of proteins. So the proteins aren't necessarily going to make it through. That's the way I think of it, okay? So you're going to have some proteins that sneak through. So you're going to have proteins in the urine, but it's not going to be as bad as with nephrotic. And nephrotic, you can probably already guess, is when the podocytes are broken down and they're not going to stop the proteins, okay? So you're going to see slight proteinuria. That's an important word there, slight. Nitrogen waste is going to build up in the blood because you've sort of clogged things up. It's getting backed up. Oliguria, small amounts of urine from decreased GFR. Yep, you've gunked things up, and so it's not going to move through. And so you're going to have a lower GFR, which your kidneys are going to respond to and say, whoa, we don't have enough fluid in the body. We need to conserve fluid, and that's going to lead to hypertension. It could also just be from a backflow kind of thing, not enough blood flowing through the kidneys in general. Edema could happen, extracellular fluid accumulation, which is associated with edema. Now, let's look at kidney diseases that could result from something called nephrotic syndrome. Okay, so nephrotic syndrome, and this is the way to remember it. Remember O in protein. Protein. Okay? Because the big difference between nephritic and nephrotic is in nephrotic syndromes, a disease, a kidney disease that is nephrotic in nature, is going to have massive proteinuria. Okay? Massive proteinuria. And that generally is from damage to those podocytes, which is going to allow the proteins to move through there. Okay? So nephrotic syndrome in general, a group of clinical findings that result from an increase in glomerular permeability. So now we're not gunking it up like we were with nephritic. Now it's breaking down, and we're losing plasma proteins. Our GFR is higher in nephrotic syndrome. Okay, so it could be a more primary disorder or a secondary complication to systemic diseases, diabetes, SLE, amyloidosis. There are different types of kidney diseases that will have more nephrotic syndrome than nephritic characteristics, but yeah. So let's just go through the nephrotic characterizations. So by increased glomerular permeability, massive proteinuria, hypoalbuminemia, lipiduria. So this is the thing to think about. Massive proteinuria, we have so if it's greater than 3.5 grams a day, well, your kidney or your liver can make about 10 grams of protein a day. But the problem is that once you start losing 3.5 a day, the proteins that make it through are kind of even more, so your kidney's trying to keep up. But even though you only have 3.5 grams per day in the urine, that doesn't mean that only 3.5 grams are getting through the glomerulus, because there's more getting through the glomerulus, but they are taken out and disassembled essentially by the tubules in the kidney. I hope that kind of makes sense. But 3.5 tends to be a magic number. When you start seeing that much in the urine, then you know that the liver isn't able to keep up. Okay, that's what that means. The liver tries to keep up, and when it does, it's making as many proteins as it can. But the trouble is, it's also making lipids. Okay, so that's something else that the kidney or that the liver does. So it's also making lipids. So you're going to see lipids in the urine. You're going to see lipids in the blood. You just see more lipids all the way around. That generalized edema that I explained earlier. Okay. So you're going to see edema because of the lack of protein. So you don't have the proteins in the blood as much. They're going to be pulled out into the tissue all over the place, with the favorite, first places that you see them, orbital, those kinds of things. But it can happen anywhere, that edema. Okay, so this is what we're looking at. So we have a lot of protein in the urine. We don't have enough protein in the blood. We have way too much lipids because the liver was kicked into overdrive to try to make up for those proteins, and it's also producing more lipids, but you have increased permeability, so you're going to see those lipids coming out in the urine. You're going to see them in the blood, so increased lipids all across the board. That's nephrotic. So do you see kind of how that's different than nephritic? Nephritic, we were clogging things up. Our GFR was lower. Here, our GFR is higher. Okay, we have a lot of proteins rather than just a little bit of an increase. You don't generally see the damage to the glomerulus as much here. So you don't really see blood as much in the urine with nephrotic. That's kind of important because hematuria was a factor in nephritic. Okay, so it's just kind of keeping these things separate. All right, so let's see, immune mechanisms, glomerular disease. So this is kind of that clogging up. So we're going to kind of talk about how some of these diseases can take place. So here is what happens with this immune complex. So something floating around, okay, some kind of antigen that your antibodies will recognize are sort of floating around in the blood, and then they bind it, and then they start to kind of clump up. And that's a type 3 hypersensitivity when that happens, when you have that and the immune cells, the antibodies start to kind of clump up. And then they will they get into the glomerulus, and then they start to kind of collect on the side of those capillaries. And that will cause damage to the capillary wall, and they get in there and they just sort of clog it up. And that's the way it works in my head, obviously, because I keep saying it. Now, another choice, instead of just being something floating around like you would see in like lupus, that's where it's just sort of floating around and the antibodies, attached to it while it's floating through the blood. You can also have antibodies that directly attack the membrane. Okay, so that's a type 2 hypersensitivity, where it's actually saying, hey, we don't like that specific collagen in the glomerulus. We just don't like it, and your immune system will attack it. And that can also cause this buildup of immune cells and antibodies, immune cells, and the entire inflammatory process. So both of these things are going to recruit a bunch of cells and can cause clotting to happen. So in general, there are diseases. This is an actual disease diagnosis, glomerulonephritis. And glomerulonephritis is, in general, that's this deposition of circulating soluble antigen antibody complexes. Okay? Caused by this type 3 hypersensitivity. Yeah, we've sort of defined this as being, in general, a nephritic syndrome. It's a nephritic syndrome because it's going to have the nephritic characteristics, glomerulonephritis does. In general, in the beginning, it could progress, and if those podocytes get damaged, it could progress to massive proteinuria and some nephrotic syndromes, or symptoms too. So mechanism is that it can be what we just looked at, either soluble antigen antibodies coming and then sort of collecting on the wall of the glomerulus, or it could be this direct attack. So antibodies reacting on specific antigens on the glomerulus. Okay. Or it could be non-immune. Okay. That's another choice. Toxins, things like that. Ischemia. So let's look at, so first of all, we're going to talk about rapidly progressive glomerulonephritis. That is severe glomerular injury without a specific cause. It's going to be a rapid decline of GFR. Focal, those are those terms. Focal and segmental proliferation of glomerular cells. So it's proliferative buildup of glomerular cells. Monocytes and macrophages are going to move in, and due to this proliferation, you're going to lose that Bowman space. Remember, you're supposed to have this capillary ball, and then the glomerulus kind of sits around it. Okay? But that proliferation is going to mean that you have a buildup of tissue around here, okay? And and macrophages, monocytes, all of those things are going to kind of be recruited in there, and so you're really kind of messing things up, gunking it up. Rapid progression, often within a matter of months, can progress to acute renal failure and death if untreated. So this rapidly progressing, we see this in certain other diseases that may cause this rapidly progressive glomerulonephritis. Systemic lupus, and that's those autoantibodies, and good pasture syndrome. Good pasture syndrome is what I was talking about earlier, where antibodies attack directly, specifically, the glomerulus. Okay, so that's where it's actually attacking it, and because it's attacking a certain type of collagen. Type 4 collagen. It's a specific type of collagen that also is found in the lungs. So that's something to remember. Good pasture syndrome, yes, is a type 2 immune-mediated, my immune system's going to attack my glomerulus disease. But because of what it's attacking, and it's also in the lungs, it's also going to affect the lungs. So good pasture syndrome affects the kidneys and it affects the lungs. Okay, in the kidneys, it leads to this rapidly progressive glomerulonephritis. There's something else called acute post-infection glomerulonephritis. I like to think of this one as kind of your immune system now, instead of it just attacking, something, well, okay. Instead of it attacking the glomerulus directly, it's associated with trying to, so it still can be a type 3, but something is getting confused. So it's some kind of mimicry. So it occurs after infection. I don't know if that was very clear. So it occurs after an infection with certain strains of Streptococcus. And so we have a strep infection, so 7 to 10 days after strep throat or other viruses such as the mumps, measles, chickenpox. Then suddenly our immune system is showing a buildup of immune complexes in the glomerulus. Okay. So that's why it's called post-infectious. Now this can go away if over time it will stop overproducing these antibodies, but these antibodies will form these complexes and they will then generate, so they fall out in the glomerulus, and then they will generate an an inflammatory response that includes complement protein. So complement protein is going to come down and it's going to start destroying anything that's been tagged, and unfortunately a lot of times this includes glomerular cells. Okay, so triggers for cell growth, so hypercellularity, infiltration of leukocytes, neutrophils, monocytes, all inflammatory types of process. Proliferation of endothelial and mesangial cells, so we have growth factors coming in there to increase cell growth as well. So that's post-infectious. So this means that some kid has strep throat, and then a little bit later they start to show signs of kidney disease. Okay, so that would probably be this post-infectious glomerulonephritis. So chronic, if it can't go away. Okay, so same kind of deal. Chronic phase of a number of types of glomerulonephritis sees so some acute forms of glomerulonephritis resolve completely, so sometimes it can go away, while others progress at variable rates, and so that's when it sort of progresses, and it's referred to as chronic when it cannot go away and it continues to progress. Some people have no history of any other glomerular diseases, and it just sort of forms and then remains chronic. And it really represents the end result of asymptomatic forms. So you may have no symptoms, but then it kind of is still doing damage. All right, so histologically characterized by small kidneys, so you have some atrophy, sclerosed glomeruli, so you're losing glomeruli. Your kidneys can shrink, and that's how you would look at it if you're going to actually look at it. Develops insidiously, progresses slowly to end-stage renal disease over a period of years. So really chronic glomerulonephritis is glomerulonephritis that sort of continues and lingers. Okay, I know that's really oversimplifying, but that's good enough. Okay, so let's see, glomerular lesions associated with systemic diseases. So we already mentioned lupus tends to be a type 3 hypersensitivity. And now we're going to talk about diabetic glomerulonephritis or glomerular sclerosis. It's sclerotic, which means you're going to have a buildup of extracellular fibrous material. This is important. Well, it's all important, right? But mechanism of glomerular change is uncertain, but affects the basement membrane and the mesangial matrix. What does that mean? That means that it's going to affect, so we've got the basement membrane is thickening, okay, with this disease, and you're also laying down fibrous material, okay? In the mesangial matrix, which means outside the glomerulus, it's cells, support cells like contractile cells or something that sort of control externally the size of the glomerulus, that kind of thing. But you see an increase in fibrotic material outside of that and thickening of the membrane. This is the important thing clinically, is that you can see this damage is going to take place. And initially it's going to kind of be, it's going to indicate more of a nephritic type of disorder, but ultimately it will move to a nephrotic type of disorder. So we're going to focus a little bit on that. So linked to those clinical manifestations, closely linked to those of diabetes, you're going to see an increase in GFR. That tends to be more of a nephrotic type of disorder, increased GFR. Initially, though, you don't see a lot of albumin, okay, protein in the urine. And the reason this is important is because it's an indication in someone who's diabetic. When you start seeing albumin in the urine, that's an indication that this disease, or that it could get worse. Okay, so that this is that the kidneys are starting to be affected. So we call this microalbuminuria. A diabetic patient comes in, you see an increase, you see elevated protein in the urine, then you can kind of maybe work backwards, or at least try to figure out if this is what's causing that. Okay, the diabetic glomerular sclerosis. So urinary albumin is greater than 30 milligrams for 24 hours, less than 300 over 24 hours. So it doesn't necessarily fall to the to those higher levels that we see with nephrotic syndrome, but it will probably move in that direction. So important predictor of diabetic nephropathies. Okay, so that's what it is. So we see this sclerosis that occurs at first, some increase in proteins, and then it can progress, and that's what we don't want to happen. So early glomerular changes can be reversed with careful control of blood glucose levels. This is caused by high blood glucose. Okay. The details of how that happened isn't known, but we do know that it's the high blood glucose levels that are causing this to take place. And so that's a patient, when they have this microalbuminuria, that needs to pay more attention, or their kidneys can just get worse and worse. So control of hypertension and smoking cessation are important to prevent strategies, and just controlling blood glucose levels. Okay, so kidneys, what happens when kidneys fail? Okay, so at some point this damage can become chronic, it can continue to cause damage, and then the kidneys will fail. Well, obviously, since the purpose of kidneys is to remove waste, then you're not going to remove as much waste if the kidneys fail. So more waste is going to remain in the blood. You're unable to regulate fluid, also a function of the kidneys, electrolytes, pH balance. These are all things that the kidneys do. They're not going to be able to do it. So it might start with acute kidney injury or acute kidney failure, and then if that continues, it will be chronic kidney injury, and ultimately renal failure. So in general, nitrogenous compounds build up the blood. Blood urea nitrogen, creatinine are the ones we think of, and usually it's a ratio of BUN, because BUN is made in the liver, and they're handled differently by the kidneys, so you can tell if it's tubular damage. We're not going to get into that, but a ratio of your BUN and creatinine. So renal function approximated by initial creatinine level versus the current creatinine level. Okay, because remember, creatinine is supposed to leave through the kidneys, and if it's not, then that's an indication, because it's going to build up in the blood. All right, so acute kidney injury. Rapid deterioration in renal function characterized by progressive azotemia. Azotemia, azon, refers to nitrogenous, and that's going to indicate that you have nitrogenous wastes building up. I say that because that's one of the things that we have to get rid of by our kidney are these nitrogenous wastes. They cannot be allowed to build up in the body because that can become toxic. Okay? So azotemia is going to show up with acute kidney injury. GFR is reduced, so reduced. Okay, so when we talk about GFR being reduced, this is because you are losing uh, you're losing your I've lost the word, your tubules, your nephrons. So you're losing nephrons, and if you're losing nephrons, then you can't filter through as much urine. So overall, when you measure this, it looks like GFR is going to be reduced. So that's going to reduce the excretion of nitrogenous waste, and fluid electrolyte imbalances are going to ensue as well. Your kidneys aren't going to be able to do their job. So it's often asymptomatic classification based on where the injury occurs, whether it's before the kidney, whether it's in the kidney directly. So before the kidney would be pre-renal, and we're talking in that case about blood flow. We're talking about ischemia. We're talking about how much blood is flowing into the kidney. So it could be intrarenal, which is damage to the structures within the kidney, or it could be postrenal, which would be obstructed urine outflow, okay, so after the kidney. So pre-renal. So we start there. We're talking about acute renal injury. If it's pre-renal, results from a marked decrease in renal blood flow. Just remember that. That's what we're talking about with pre-renal. We're talking about blood flowing into the kidney or not. Okay, so so most common form of acute renal failure, etiology is profound loss of circulating vascular volume. So hemorrhage could cause this, somebody bleeding out, bleeding somewhere else, shock, low blood pressure, and so the body may respond by reducing blood flow to the kidneys, or you just can't get enough blood flow to the kidneys. So that would be pre-renal. You're not getting the blood to the kidney. Vasoconstriction could happen in a number of different ways. Vasoactive drugs, endotoxins, NSAIDs, something that's just triggering vasoconstriction. Clinical manifestation: ischemic changes seen when renal blood flow is 25% of normal. So we've dropped it to 1/4 of what it usually is. And this can lead to something that we'll talk about called acute tubular necrosis, which is intrarenal. So if you think about what that means, it's saying that if you're not getting enough blood flow to the kidney, that's pre-renal, but it's going to cause damage in the kidney, which is intrarenal. Okay, so sharp decreases in urine osmotic pressure, so that's an early sign due to less sodium being filtered. Okay. Makes sense. Disproportionate elevation in the ratio of blood to serum creatinine to greater than 20:1. Normal is about 10:1. So that's that that ratio is going to be elevated if it's pre-renal. All right. So normally GFR is maintained despite a broad range of renal flow. So you usually have control, but if you've reduced blood flow too much, then your GFR can be affected as well. Okay, so intrarenal, inside, so results from conditions that cause damage to glomerular, so that includes the glomerulus, the tubules, the renal tubules, interstitial, so outside the other structures around the tubules, anything within the kidney. That's all we're talking about here. So we're going to talk about a disease called acute tubular necrosis. And that's going to be caused by this ischemia. So this lack of blood flow, this pre-renal problem can lead to this intrarenal problem. So etiology is ischemia, yes, associated with pre-renal failure, damages structures in the kidney. Glomerulonephritis can cause this. Acute pyelonephritis, which we discussed as well. Any of these things can lead to an intrarenal problem. So let's talk about acute tubular necrosis, a type of intrarenal concern issue. We've talked about the glomerulus. We talked about the the pelvis of the kidney. So now we're going to actually talk about a disease that affects the tubules. So this is destruction of tubular epithelial cells with acute suppression of renal function. Well, yeah, there's going to be suppression of renal function because these tubules are supposed to be directing this reabsorption, which is not going to take place the way that it's supposed to. It could actually leak out, or it could get clogged up, or both. If it gets clogged up, it's going to push out and cause leakage of fluid, and you've sort of lost function of that particular tubule. Okay, so this can get very bad if it affects a lot of nephrons. Most common cause of intrinsic intrarenal failure, that's what acute tubular necrosis does. High-risk groups, major surgery, severe hypovolemia, overwhelming sepsis, trauma, burns, so lots of different things can lead to a disease where you end up with injury to the tubules and then the obstruction, leaking, and loss of function. So GFR does not improve with restoration of renal blood flow. That's an indicator. So that means that usually if we get more blood flow if we get some vasodilators or something to open up blood flow to the kidney, the GFR is not going to change because that's not the real problem. The real problem is getting the fluid to move through. Okay, so yeah, you're not going to be able to improve your GFR if your tubule is not functioning properly. Okay, so post-renal. So we're moving past the kidney, and now we're moving out of it. And we already kind of discussed the stuff with obstructions. Okay, so results from obstruction of urine flow from the kidney, least common. And obstruction may occur in the ureter, bladder, urethra, which is more common. So it's less common to see an obstruction of flow from the kidneys, and it's more common to see an obstruction of flow from the urethra in the lower urinary system. Okay? So both ureters must be occluded to produce renal failure. Yeah, because if you've because you've got another one to take its place, essentially, is what's going on there. The goal of treatment of the underlying obstruction prior to permanent, the goal of treatment is to remove the obstruction prior to permanent nephron damage. So we want to get rid of the obstruction. So we've already kind of mentioned this. Something's blocking, backing up, and can back up and actually cause damage to the kidney. Okay, so the clinical course of renal injury, onset, hours to days, which makes sense because it's acute. Time from onset of the precipitating event, ischemia, toxin, until tubular injury occurs. Okay, so that's your onset. You're going to see a marked decrease in GFR resulting in sudden retention of urea, potassium sulfate, and creatinine. So your reduction in GFR is going to cause these things to become backed up and remain in the blood. Your urine output is going to be lower, so oliguria. Your fluid retention is going to cause edema, water intox, pulmonary congestion. Okay? So this is because your kidneys are failing or injured, and they're not able to allow the blood flow to flow through, whatever the cause. So neurological manifestations of uremia progress if it's untreated. So that makes sense. All right, so repair of renal tissues can take place. This is a happy thing. Now we're recovering. And onset marked by gradual increase in urine output, fall in serum creatinine, more accurate, which would be more accurate than BUN because BUN is also being produced by the liver. Eventually, tubular function is and the way that it's handled. We didn't get into that. But eventually, tubular function is restored with improvement in urine concentrating ability, and BUN and creatine return to normal. So things go back. You get tubular function returned. Okay, so that's recovery. Some mild to moderate kidney damage may persist. Okay, that's a happy ending. Chronic kidney disease is when you don't have, it continues, it's progressive, it's irreversible, and you have destruction of these kidney structures. You lose nephrons. Okay, so nephrons will continue to die, the kidney will continue to atrophy and get smaller, and your GFR is just it's also going to deteriorate because without enough, when you've got only a few, nephrons trying to handle all that blood flow, they're not going to be able to move as much fluid through it. So that's going to be seen as a reduction in GFR, continual progressive reduction of GFR. If you don't have tubules, you're not going to have the reabsorptive capacity, endocrine functions, all of this stuff can be damaged. Etiologies include conditions that cause permanent loss of nephron, diabetes. So what causes it? Diabetes is a big one. Hypertension is a big one. Some glomerular damage from glomerular disease is glomerulonephritis. Polycystic kidney disease, formation of cysts within the kidney. All of these things can cause damage, and those nephrons, a lot of times, when they're gone, they're gone. Okay, so that's a permanent loss of nephrons. So the symptoms occur gradually, not evidenced until the disease is quite far advanced. Each kidney contains about 1 million tiny nephrons, and you lose them, just sort of one by one. Proportional relation exists between the number of nephrons affected by the disease and the resulting glomerular filtration rate. Okay, so that's what I mentioned earlier. If you don't have the nephrons to filter it, then you're going to have lower filtration rate. Okay, mechanisms, manifestations. I want to go through a few of these. Some of these just make sense. If you have chronic kidney disease, if your kidneys are failing, then you're not going to be able to handle sodium and water balance as well, okay? Which can affect hypertension. Heart failure can result. Potassium balance, same thing. You're not going to be able to cover that. You're not going to be able to eliminate nitrogenous waste. They're going to build up in the blood and cause a number of different effects. Okay, skin disorders, sexual dysfunction. I'm not sure how exactly. I'm sure there's a way if I thought about it. GI manifestations. So problems can happen from that. This is a big one. This is a big popular test question kind of one, and that is erythropoietin. We cannot forget that erythropoietin is made by the kidneys. What does erythropoietin do? It causes the production of red blood cells. It tells your red blood cells, or it tells your bone marrow to produce more red blood cells. It's made in the kidney. Therefore, if your kidneys fail and they don't make the erythropoietin that they're supposed to, that's going to lead to fewer red blood cells, and which we call anemia, or oxygen carrying capacity reduction. We call anemia. Okay, so don't lose sight of that connection right there. Acid-base balance, yeah, that's also handled by the kidney. Vitamin D activation, vitamin D is activated by the kidney, so that won't happen, which can lead to hypocalcemia. Phosphate elimination, which is also involved in bone, and so we end up with osteodystrophy. So we end up with bone problems resulting from chronic kidney failure. Okay, so we just went through and we just talked about these kidney injury, how kidney injury affects these things: sodium, water balance, potassium, anemia, acid-base, calcemia. Clotting is also affected. There's a clotting factor that will start to, or an anti-clotting factor that can be lost in the kidneys. Also, stasis of blood flow tends to happen, so you have increased clotting. So that can take place. That's another thing to remember. That increased clotting can take place, not necessarily the mechanism, because I really didn't explain it. And these are your signs and symptoms. So that's it for